Good evening, respected chairpersons and friends. I will be presenting you about our experience regarding Gracz fistula. We all know AV fistula is a best form of vascular access, and we know where various sites where fistula can be created. Distal radiocephalic, we can do elbow fistula. Elbow fistula could be brachiocephalic, or it could be brachiobasilic also. Gracz fistula is a fistula between perforating vein to the artery. So there is a perforating veins are veins which drain superficial vein to deep veins. So to show in a picture, this is arrow shows the perforating vein which is going down. It is tied and it is cut. On left of your screen is a brachial artery which lies medials to it. So you do arteriotomy and then anastomose this perforating vein to brachial artery, and this is the final result which you get. Benefit of Gracz fistula is because the perforating vein is connected to medial cubital vein, your both cephalic as well as basilic vein develop over the period of time. So in our center, all AV fistula surgeries, all kinds of fistulas are created by nephrologists, myself and my colleague, and over the period of 2 years, I am presenting a data related to Gracz fistula. So primary outcome was short-term fistula patency, that is within first 24 hours, as well as medium-term patency up to 3 months, and fistula maturation and complications were secondary outcomes. Short-term patency was defined as clinically audible bruit with color Doppler evidence of patent AV fistula in first 24 hours, whereas medium-term patency added a criteria of cephalic vein blood flow more than 600 ml per minute in arm in between 2 to 3 months. So this analysis happened between 2 to 3 months after surgery. Maturation, AV fistula was considered mature if it was successfully cannulated with 16 gauge needle with flow rate more than 250 mils. Over this period, we constructed 53 Gracz, out of which 41 were left Gracz and 12 were right Gracz. This constitutes about 11% of our all AV fistula work and about 1/3 of our all elbow AV fistula work. And in all cases, anastomosis was end to side between perforating vein to brachial artery. Male outnumbered females and comorbidities were as expected, diabetes and hypertension, and both genders were comparable with respect to comorbidity. So coming to results, out of the 53 patients, 51 patients had short-term patency, that within 24 hours only 2 patients had thrombosis. Out of this 51, over the period of 3 months, 2 patients died and 2 lost for follow-up. So we had 47 patients available for assessment of medium-term patency. 91% was medium-term patency observed, of which 2 patients had maturation failure. In summary, out of 53 patients, primary patency rate was 96%, whereas medium-term patency was 87% and maturation rate was about 82%, which are impressive numbers. Among complications, we observed delayed wound healing in 1 patient and limb edema. Otherwise, there were no other major complications. Important points which I want to mention here is, like constructing a Gracz fistula is an on-table decision. Because perforating vein cannot be assessed by Doppler or venogram in preoperative period, and it may not be consistently present. There can be variation in location, like if it is away from brachial artery, you may not be able to do this surgery. And many times there is a short segment which is available for anastomosis, and quite frequently, although it is difficult to assess the diameter of that vein, but these are small veins, but the fistula works well. The first report came as expected from Kenneth Gracz. That's why it is labeled as Gracz fistula, 1977 in Kidney International. But there is very limited literature available about this fistula. This is another paper which mentions superior patency of Gracz fistula for hemodialysis. So to conclude, Gracz elbow fistula is an innovative form of fistula, and unfortunately it is underutilized method of AV fistula. In this, this is innovative because you are using a deep vein in this situation. Otherwise, in all other fistulas, otherwise we utilize superficial vein. It seems to have good success rate, and I presume that it can be performed by us, we nephrologists. Thank you.
What was the long-term survival over a year? What is your follow-up of these patients?
So long-term follow-up, we have not analyzed. We have analyzed this up to only 3 months.
When do you go for a Gracz fistula? Do you first do the ultrasound, and if you go with the preformed idea, or
No, that's
you
what I
get
have
it
already
on the
mentioned,
table?
that it is difficult to map this vein because it's a deep vein. You cannot assess diameter of this vein, and you cannot even assess it with the help of venogram. So it is an on-table decision, and obviously to do Gracz fistula, you have to take below elbow incision. Like the surgeons who are doing above elbow fistula, like elbow fistula with above elbow incision, like most of the surgeons do end to side cephalic vein to brachial artery fistula, and where incision generally is horizontal above elbow crease. So in that situation, there is like you don't have that option. In our practice, we generally do take a below elbow incision. If I take a below elbow incision, and if I like mentally feel that Gracz fistula is feasible, my preference always is to Gracz fistula than other kinds of fistula. Like you can do a side to side fistula there. You can below elbow you may even get good radial artery also. So like proximal radial artery to median antecubital vein, that is also option there. So on table, it is an on table decision, and if I think that Gracz fistula is feasible, I will always go for Gracz fistula. And probably that is the message also I want to give through this paper, that whenever there is a feasibility of Gracz fistula, we should utilize this opportunity, because success rate is very good. Also, it gives you an insurance vein, like in addition to cephalic vein, there is chance for basilic vein to develop.
Yes, you are right. Because if you are not able to find a cephalic vein in the forearm, you go with the planning that you are doing it at the elbow. But if you get a good perforator, you should always go for a Gracz fistula, and you should give incision below the elbow. Because if you have given it above elbow and you are anastomosing it with brachial artery, later on there are some complications, you will have to do the surgical intervention. Yeah. But if it is in the radial artery, if you have anastomose, then you can easily even tie the radial artery if there is any complication.
Yeah. I'm sorry for the interruption, Mr. Chairman. We'll have to move on as the time for this presentation is up. Thank you.
Thank you very much.